This danger zone, marked in red, extends from the inferior border of the zygomatic arch to a line above the bony lateral canthus. The zone curves anteriorly as shown from the lower line to the upper one. Within this zone, the temporal branch of the facial nerve is vulnerable to injury where it passes superficially in the superficial temporal fascia. Facial danger zone 2 is best localized by drawing three lines define a triangle in which the temporal branch of the facial nerve lies on the undersurface of the temporoparietal fascia SMAS layer. A line from a point 0.5 cm below the tragus to a 0.2 cm above the lateral eyebrow. A second line is drawn along the zygoma to the lateral orbital rim. A third line is then dropped from the point above the eyebrow to the zygoma. Facial danger zone 2 includes the area where the temporal, or frontal, branch of the facial nerve runs under the temporoparietal fascia SMAS layer. Injury to the temporal branch results in paralysis of the frontalis muscle. Orbicularis oculi function is spared following temporal branch injury because the muscle receives dual innervation from the zygomatic branches inferiorly. Dissection in facial danger zone may second be carried out deep to the temporoparietal fascia SMAS layer, or subcutaneously above this layer, but not immediately beneath the temporoparietal fascia SMAS layer. Marino advised to develop mesotemporalis by dissecting the subtemporoparietal fascia SMAS layer from the scalp toward the supraorbital rim down to the level of the zygoma and dissecting the supra-SMAS layer subcutaneously in the cheek from the mandibular ramus up to the zygoma. The point at which these two planes meet reveals the SMAS layer, or mesotemporalis, in which the temporal branch of the facial nerve resides. Facial danger zone 3 is best described by drawing a point on the middle of the mandibular body 2 cm posterior to the oral commissure and drawing a circle with a radius of 2 cm around this point. Facial danger zone 3 includes the marginal mandibular branch of the facial nerve at a point in its course where it is most vulnerable anteriorly as the platysma SMAS layer thins and the nerve courses superiorly to innervate the depressor anguli oris muscle. Note the proximity of the anterior facial artery and vein to the marginal mandibular branch of the facial nerve, which easily explains the injury to this nerve seen after attempting to cauterize a bleeding point in these vessels. Injury to this nerve creates a noticeable and extremely distressing deformity, especially when the patient smiles. During grimacing, the denervated depressor anguli oris muscle cannot pull the corner of the mouth and lower lip down, resulting in an inability to show the lower teeth on the affected side. Injury to the marginal mandibular nerve occurs most commonly during subcutaneous dissection in zone 3, either from above, deep to the cheek flap, or from below through a submental incision. Injury typically occurs when trying to communicate these two areas. The marginal mandibular nerve in facial danger zone 3 can be injured easily by electrocautery for the facial vein or the facial artery. The facial artery and vein lie immediately medial, deep, and adjacent to the marginal mandibular branch of the facial nerve. Posterior to the facial artery and vein, the platysma SMAS layer is thicker, providing greater protection for the marginal mandibular branch of the facial nerve during dissection in the subcutaneous plane. Facial danger zone 4 is located deep to the platysma SMAS and parotid fascia. This space is triangular and is anterior to the parotid gland, superior to the mandibular body, posterior to the zygomaticus major muscle, and superficial to the masseter muscle and Bichat's fat pad. This zone can be estimated by placing 3 dots, one over the highest point of the malar eminence, another over the posterior border of the mandibular angle, and a third dot over the oral commissure. A triangle is then drawn connecting these 3 dots. Facial danger zone 4 includes the zygomatic and buccal branches of the facial nerve, which are superficial to and rest on Bichat's fat pad. Injury to these nerves can result in paralysis of the zygomaticus major and minor muscles and levator labii superioris iliac nasi muscle, causing the upper lip and oral commissure on the affected side to sag. The zygomatic and buccal branches interconnect freely, thus paralysis is usually not permanent. Injury to the zygomatic and buccal branches should occur only when the plane of dissection is beneath the SMAS. The zygomatic branches are most superficial just before running underneath the superior portion of the zygomaticus major muscle near the muscle's origin from the zygoma, and injury is most likely to occur here. Note the lateral border of the zygomaticus major muscle near its origin from the malar eminence and the dangerously superficial course of the zygomatic branches before their innervation of this muscle. Exposure during rhytidectomy in which the orbicularis oculi muscle is elevated as well as the platysma muscle, creating a bipedical musculocutaneous flap. Incision of the parotid fascia SMAS along the anterior border of the parotid involves a greater risk of buccal and zygomatic branch injuries than incision of the parotid fascia more posteriorly. Facial danger zone 5 is best localized by identifying the supraorbital foramen, which can be palpated along the supraorbital rim, usually directly above the mid-pupil. A circle with a radius of 1.5 cm is drawn around the point. This circle defines facial danger zone 5. A vertical line is dropped through the supraorbital foramen, the mid-pupil, and down to the second mandibular premolar to identify the infraorbital and mental foramina, making subsequent localization of facial danger zones 6 and 7 much easier. Facial danger zone 5 includes both the supraorbital and supratrochlear nerves, which are branches of the first division of the trigeminal nerve, cranial nerve V. The supraorbital nerve courses deep to the corrugator muscle, while the supratrochlear nerve actually courses through the muscle. Both of these nerves are susceptible to injury as they emerge from the bony foramina where they are more adherent and less mobile. Injury to these nerves results in numbness of the medial forehead, scalp, upper eyelid, and nasal dorsum. Injury to the supratrochlear and supraorbital nerves within facial danger zone 5 occurs typically when a coronal brow lift is performed either alone or in conjunction with a lower face lift. As the dissection approaches the supraorbital rim, the surgeon must be careful not to injure these nerves as they exit their respective foramina. When excising a thin layer of frontalis muscle, leave a small island of temporoparietal fascia SMAS and frontalis muscle with the accompanying nerve and vessel intact at the junction of the lateral and medial third of the coronal flap on each side. In the course of dissecting the corrugator muscles, be careful to avoid injury to the supratrochlear nerve. The supratrochlear nerve runs within the fibers of the corrugator muscle.